micro and move to the macro. So for our micro here, we can talk about our sensory nerves. There's a lot of information on this slide. You need to know these different names of these different types of sensory nerves, and you definitely need to know the different types of free nerve endings. But I don't think a strict memorization of this chart is entirely necessary, so we're just going to kind of go through it once and move forward. So for our free nerve endings, this is one I really want you to know. Our C-type are slow, and they are unmyelinated fibers. Okay. Our A-delta type are fast, and they are myelinated fibers. We see this in all of our skin, epidermis, and some visceral organs. This is responsible for somatic pain. When we say somatic pain, that means pain that we can detect, that we can feel. Okay, and so that is obviously our skin, the epidermis of the skin, and it's all responsible for pain and temperature. Pain and temperature. Our Meissner corpuscles are large fibers. They're myelinated. They adapt quickly. They are going to enable us to detect fine and light touch. If you have someone lightly touching you on your arm, you'll detect it at first, but after a second it kind of goes away. You can do it to yourself right now, and it's almost hard to feel it. So these are adapting quickly, and that's what they're responsible for. These are the Meissner corpuscles. Okay, we find this on hairless skin, meaning the skin of our hands, and I guess depending on how much skin you have on your body, other parts too. Pacinian corpuscles, again, large myelinated fibers. Here, these are located in deep skin joints, ligaments, joints. These are going to detect vibration, and they're also going to detect pressure and stretch. Okay, so we don't want our joints to be being stretched too much, and so Pacinian corpuscles can kind of help us detect how much we're stretching and prevent rupture of our muscles, for example. So ligaments and joints is where we find those. Our Merkel's discs are located in our fingertips, superficial skin. This is more for our deep touch, okay? Sharp edges and our position sense. Last, our Ruffini corpuscles. Corpuscle is just so fun to say. Corpuscle, I love saying that. So this is our dendritic endings with a capsule. They adapt slowly, and these are responsible for detecting pressure, kind of like esoteric stuff like slipping of objects along the skin. The angle of our joints are detected by our Ruffini corpuscles, okay? And so, you can see that sort of all of these corpuscles and discs are all sort of responsible for pressure in one way or another. And our free nerve endings are responsible for pain and temperature, okay? Our Meissner corpuscles are responsible for that fine and light touch. But otherwise, it's mostly just pressure. Okay, so those are our sensory nerves. We can kind of take a look at where some of them are located. You can see some of our free nerve endings here. Our Merkel's receptors. Here's our Ruffini's corpuscle. Meissner's corpuscle is a little bit more superficial. And the deepest is going to be our Pacinian corpuscle. Okay? Great. So getting into what the spinal nerve and spinal cord looks like. So we said where the nerves are. So where is all that information actually arriving? And so what we can see, to diagram it on here, if we have, say, a hand out to the side here, here's our hand, and here's a fire, we detect a little bit of a burning sensation, and so the free nerve endings that are here at the periphery are actually going to have axons that move up the arm, through the axilla, through the spinal canal, and now into our spinal cord. The axon continues on. We haven't gotten to the nerve body yet. This is just axon. We had a free nerve ending and an axon that's going to move all the way into the dorsal root. And then here at the dorsal root ganglion, we will finally find the body of that nerve. Can you believe it? The nerve ending was all the way here out on the arm. I mean, stretch your arm out and just look at all that distance. There is no nerve body there. The body of that nerve is all the way in the dorsal root ganglion, in the spinal cord. It's crazy. It's crazy. It goes so far. And so that axon is going to continue forward, ultimately synapsing in the dorsal horn of our spinal cord. Okay, so now we can talk about our spinal cord here. We have a dorsal horn. We have a ventral horn. All of the horns are consistent of gray matter. And when you say gray matter, I want you to think of nerve cell bodies. Okay? Gray matter always means nerve cell bodies. I'm sure you know this. White matter is always axons. Okay? So why does it look white? Because of all the myelin. Myelin is important for conducting those signals quickly. And so because we have axons in white matter, that's why it looks white. All that myelin. Okay? So dorsal horn, ventral horn, those are all gray. They all represent nerve bodies. And all of our white matter is all due to axons. Great. So we have a synapse here on another nerve. This nerve is either going to cross over the spinal cord. It's going to start traveling up on the same side. We'll talk about what goes where shortly, but just to know that the next nerve body is going to be here in the dorsal horn. Okay? So if I'm telling you that all the sensory information is here in the dorsal horn, what is this whole ventral horn for, right? We haven't said anything about the ventral horn. So ventral horn, this is more towards the front of the body, and this is going to have a nerve cell that is going to travel out of the spinal cord. Okay, so why do we need a nerve cell to travel out of the spinal cord? Well, how are we going to control our muscles, right? How are we going to control our nervous system? How do we make conscious choices and execute those choices? We need a nerve cell body that shoots an axon out to the hand and triggers those muscles of the hand to contract and get away from that fire. Okay? And so, big picture wise, we have a ventral horn that's responsible for motor, and our dorsal horn is responsible for sensory. Okay? And we're going to go through and kind of break that down. There's a lot of different kinds of senses, and motor is an interesting way that it is transmits the information as well. So we'll kind of break that down and talk about how that is done. Okay. Do you have any questions before we kind of get into more detail here?
I'm okay.
Good. Good. Okay. Great. So we're going to draw all these out, but I kind of want to give you the vocabulary before we do that. So when we have our spinal cord here, it's organized. Here's our horns, great. Here's our horns, great. Okay. Now, our spinal tract has different anatomy and functions. So there are three major tracts in terms of sensory and motor, and how that information is transmitted through the spinal canal. So our dorsal column represents this area in the dorsal part of our spinal cord. Okay? Dorsal column is going to be responsible for transmitting pressure, vibration, fine touch, and proprioception from the periphery to our brain. Okay? So all the axons live in this area. Okay? The cell bodies live where? Here in our dorsal horn. I told you that already. And the bodies are going to live here in the axons are going to live there in the dorsal column. Okay? Great. So the first neuron. Each of these are going to have multiple neurons involved. For sensations, we have 3 neurons involved. For motor, we have 2. For our pressure, vibration, fine touch, proprioception, the first order neuron is going to have that free sensory nerve ending. That is going to have its cell body in the dorsal root ganglion, what we described just in the last slide. That will enter the spinal canal and ascend on the same side in the dorsal column. So here we have information entering. Here's the cell body in the dorsal root ganglion. It enters the spinal cord and it's going to ascend ipsilaterally. Okay, so we do not have a synapse yet. It has not yet synapsed on another neuron. The first synapse is going to be in the nucleus cuneatus or gracilis, which is in the medulla. Okay, so just to blow your mind a little bit further, the sensory nerve ending in our fingertip is going to travel all the way up our arm, through the axilla, all the way to our spinal canal. It's going to enter the spinal canal, and then it's going to travel all the way up to the medulla before it synapses. So you have nerves that go from the tip of your toe all the way to your spinal canal, all the way up your spinal column, all the way to your medulla. And it's the same nerve. How crazy is that, right? That's like, I don't know how tall you are, but for me that's like 5.5 feet of nerves, of a single nerve, right? So it gets to the medulla, and there it's going to synapse. The second order neuron is going to cross sides. So now it crosses to the contralateral side. and then it's going to ascend contralaterally in the medial lemniscus. The second synapse is going to be in the thalamus, and then the last nerve is going to be in the sensory cortex, where we finally will process this sensory information. Okay? So, dorsal column, responsible for vibration, fine touch, proprioception. There's 3 nerves involved. The first nerve doesn't synapse until you get to the medulla. Second nerve is going to cross over and synapse in the thalamus. And the third nerve is in the sensory cortex. Okay? Boom. Done. Next tract. Our spinal thalamic tract is responsible for pain, itch, and temperature. Pain, itch, temperature. Don't worry about this one. Okay, pain, itch, and temperature are responsible, are transmitted by the spinal thalamic tract. Okay, so again, we're going to start with a similar story as our dorsal column here. We're going to start with a sensory nerve ending in the periphery. It has the cell body in the dorsal root ganglion, and it's going to enter the spinal cord. As soon as it enters the spinal cord, it immediately synapses. Okay, so unlike our pressure, vibration, fine touch, where you have a nerve that goes all the way from the tip of your finger all the way up to your medulla, here we have a nerve that goes from the tip of our finger into the spinal canal and then synapses. That's one nerve. Okay? Does that make sense, the difference there? With dorsal column, it goes from the tip of our finger all the way up to our medulla before it synapses. With our pain, itch, and temperature, it's one nerve that goes from our periphery into the spinal cord, and then synapses. Okay? Great. So as soon as it synapses, it's immediately going to cross over. Okay, so let's see what that looks like. Here's our spinal cord again. Okay, we have the nerve coming in. We said it immediately synapses, so that's the end of the line for this nerve. It's going to synapse on the second order nerve. That second order nerve is immediately going to cross over the anterior white commissure in the spinal cord and begin to ascend. Okay, so we said that for dorsal column, it doesn't cross over until we get to the medulla. For spinal thalamic, it crosses over immediately. As soon as it gets to the spinal cord, it crosses over. Okay, it's going to ascend contralaterally on the opposite side. Where does it synapse? Same spot in the thalamus, and the third order neurons in the sensory cortex. That's convenient. It's the same thing as the previous tract. Okay, so the big difference is here. Where is the first synapse? Where does the decussation occur? Where does it cross over? Okay, decussate means cross over. Where does it cross over? That is what you need to know for USMLE and what you're going to get questions on. Our lateral corticospinal tract is responsible for voluntary movement of our limbs, and this is going to be a descending tract, right? It has to go from the motor cortex down to the muscles, so it's got to be descending. So our first cell body is going to be in the motor cortex. It's going to descend on the same side through the internal capsule, which is just a geographical part of our brain. Most of the fibers at that point will decussate at the medulla. Okay, so for upper motor neuron, it decussates at the medulla, it crosses over at the medulla. Okay, it's going to descend on the opposite side of so if we have our right brain that says, I need to move my arm, it's going to send a signal saying, I'm going to move my arm. That signal is going to go down through our brain to the medulla. At the medulla, it's going to cross over. That signal is going to continue down all the way to the arm, and then you're going to move the right arm. Okay? That's the left brain moving the right arm. Right brain will move the left arm. Okay? Because we're crossing over at the medulla. That's the reason for that. Okay? So the first synapse is going to be in the anterior horn of the spinal cord. Okay? So here is our anterior horn is going to be here. And so we have a synapse, we have the nerves coming down, synapsing, and then our second order nerve is going to leave the spinal cord and synapse directly onto the muscle. Okay, here's our muscle. So just kind of tracing this back again, we have our cell body in the primary motor cortex. That's going to descend on the same side through the internal capsule and then decussate, cross over, at the medulla. After that, it's going to continue down on the opposite side of where the primary nerve body was. It's going to synapse in the spinal cord at the anterior horn. That next nerve is going to leave the spinal cord and synapse on the muscle. Okay? So, let's draw this out really quickly. One more time. We're going to start with our dorsal column. Okay? So, dorsal column is responsible for what kind of sensations? Eva, can you tell me? Our dorsal column, our spinal thalamic, and our motor. The dorsal column would be responsible for what kind of sensation?
Sorry, can you repeat?
Sure, no problem.
Vibration. Is that one that you are asking me?
That's the one, yep. So this
Vibration,
would be,
tone, touch.
yep, vibration, fine touch, and proprioception. Where are my body parts in space, right? Is it pointing up? Is it pointing down? We can sense that because of our dorsal column, okay? So great. So here is our little bit of spinal cord. Here is our medulla, and here is the sensory cortex. Okay. I know I should have been an artist. I could have skipped art school and everything, but here I am. Okay, so here is the hand. Okay, and so the hand is going to detect some little bit of vibration or touch. That signal is going to travel up the arm, and the cell body is here in the dorsal root ganglion. Okay? It's going to travel into the spinal cord, and then it's going to travel up the dorsal column. Okay? So here's our dorsal column. It travels up the dorsal column. In the medulla, it's going to synapse. Okay? And this synapse is going to cross over the medulla and up to the thalamus. Okay. Here's the thalamus, the VPL of the thalamus, and then that is going to synapse on the third nerve in the sensory cortex. Okay. Great. So that's our vibration and touch. Our spinal thalamic pathway. Okay. So here's our sensory cortex. Here's our thalamus. Here is the medulla. Here's our spinal cord. And here's our hand. Let's do this again. And this is something that I'd encourage you to practice at home, you know, sort of drawing out these pathways so that you're comfortable where they all cross over, where they all synapse. So here is the sensation of, oh my God. Oh, I hate when that happens. Okay, let's just draw this out one more time, no problem. Okay, so here is our sensory cortex, the thalamus, medulla, spinal cord, and here's the hand. Okay, and we are doing our spinal thalamic pathway. Spinal thalamic, pain, itch, temperature, any of those here will be transmitted. We're going to have our cell body again in the dorsal root ganglion, and then as soon as this nerve enters the spinal cord, it's going to immediately synapse. Okay, as soon as it synapses, guess what? This nerve is crossing over. It will travel up the spinal cord, up through the medulla. It'll synapse in the thalamus. This next nerve will cross to the opposite side sensory cortex, and that will be the final nerve of the pathway. Okay? So 3 nerves in this pathway. We have the pain that's being transmitted. First synapse here in the spinal cord. We have an immediate crossover, and that information will travel up through the medulla as synapse in the thalamus and ultimately synapse in the sensory cortex. Okay? Last is going to be our motor. Okay. So motor is very different from the last 2 we talked about because motor only has 2 neurons. Okay? And so there's the motor cortex. Here's our medulla. Here's our spinal cord. Here's our hand. And let's look at how this motor nerve is going to travel. Okay, so we have a motor nerve on this side, and it's saying I need to move my arm. So the motor nerve is going to travel down. The pathway that it takes through the brain is called the internal capsule. Okay, if you hear that terminology, internal capsule is the way that this motor nerve is going to travel through the brain. Once the motor nerve reaches the medulla, it's going to cross over to the opposite side. It'll continue traveling down the spinal cord, entering at the level that it needs to, and so we have our gray matter here, which is where all of our nerve bodies are. It'll synapse on the anterior horn and onto another secondary motor or lower motor neuron. This lower motor neuron will progress to the muscles that we want to move and synapse directly onto the muscle. Okay? Questions on this? Anything that makes sense?
I'm okay. I love the drawing. I'm going to try to do that because that way I'm not going to forget anything.
Yes, you gotta.
That's a good idea. I never did like that, so I like it.
Draw it to know it. As long as you, and I really hope that you sort of have a mental picture of like what I'm trying to draw here, and it's not just like some abstract thing. But as long as you have some idea, you got to know where the bodies of these nerves are. You got to know where they cross over, and you got to know where they synapse. Those are the three things you need to know for this. You really, I think a lot of times we make it more complicated than it is. It's really actually pretty straightforward. Just memorize those few things, and you will be okay. Now, for our upper and lower motor neurons, they each have a different job. Okay, so our lower motor neuron is going to be responsible for contracting muscle. Whenever you think of lower motor neuron is that ADHD kid in class who is constantly just doing things, just always wants to move his muscle, okay? So when you see lower motor neuron, I want you to think of like spastic. Like spastic is like a very contracted, very active, that's a lower motor neuron. Our upper motor neuron is that teacher in the class who says, no, you should not be running around, you should be sitting at your desk, you should not be spastic right now. Okay, so instead of being spastic, this is more of a relaxed, almost flaccid. Okay. Okay, great. So upper motor neuron's job is to make things flaccid. Lower motor neuron's job is to make things spastic. Okay, so if you lose your lower motor neuron, upper motor neuron's going to win. If you lose your upper motor neuron, lower motor neuron's going to win. Okay, there's a balance here that happens when it comes to losing one of these two neurons. You're going to get a lot of questions on this particular topic. So if it's not making sense, please stop me so I can draw it out and review it for you. Okay. Upper motor neuron is the neuron that comes from our brain and synapses in the spinal cord on the opposite side. On the lower motor neuron is going to go to the muscle. Okay. So what happens when we lose our upper motor neuron? Say we have a car accident and we sever the spinal cord, and now we've taken out our upper motor neuron. Okay. So what's going to happen? Well, there's no upper motor neuron, so this kid is in class with no teacher, so spasticity is going to win. Okay, so let's look at what that looks like. So with an upper motor neuron lesion, we have some weakness. Our patient is not able to make a choice, I want to move my arm, because they've lost that upper motor neuron that sends that signal. So we will see weakness. No atrophy, no fasciculations, however, reflexes will be very strong. We said lower motor neuron is all about spasticity. It's all about activity. And so the reflex is going to be boom. It's going to be right there. The muscle tone is going to be very high because lower motor neuron loves being spastic, loves being strong. So if we take out the upper motor neuron, no one's in charge. Lower motor neuron is going to be all about that tone and muscle. Babinski reflex will be there because all of our neurons are intact. We'll have spastic paralysis. Lower motor neuron is all about that spasticity. Okay, no flaccidity. Our upper motor neuron's gone. It's not flaccid. And we may have some clasp knife spasticity as well, where clasp knife is where we have a patient with their arm contracted like this. I don't know if you can see me, Toby. Obviously you can't see it, but if you kind of like flex your bicep, right, and bring your fist close to your own chin, that is the clasp knife. And so with clasp knife, when you try and move the patient's arm, they're going to resist it very strongly until when you put enough force, they're going to release it very quickly. And now it's going to be sort of flexed all the way open. Okay? So your patient is going to go, if this is the arm, right, this is the fist, this is the elbow. Okay, so this is the clasp knife. As you try and pull in this direction, they're going to resist that quite a bit until you put enough force, and then they're going to completely extend their arm straight out. And here's the elbow. Okay, and so that is the clasp knife spasticity, and that's something that you see in an upper motor neuron lesion. Okay, so that is upper motor neuron. Now, let's go back to this diagram, and let's say instead, so here's our upper motor neuron coming from our cerebral cortex. It's crossing over at the medulla, synapses in the anterior horn. Here's our lower motor neuron going out and synapsing directly on the muscle. And let's say somehow we had a surgery go wrong, and instead we lost our lower motor neuron, but our upper motor neuron is good. Okay, so we said that upper motor neuron is all about flaccidity. It's the teacher in charge of this class. It's saying sit down, sit down, sit down. And now there's not even a kid in this class. Okay, so now flaccidity is really taking over, and relaxation is really taking over. So what are we going to see? Weakness. There's no nerve going to the muscle. So obviously, we're going to have a very weak muscle. If no nerves are stimulating a muscle over a long period of time, that muscle is going to become atrophic and start to degenerate. Okay, so looking for atrophy of the muscles. Fasciculations. As the muscle is not getting any stimulation from a nerve, the muscle is actually going to start to express more receptors for acetylcholine. We know that lower motor neuron releases acetylcholine on the muscles, right? That's how this system works. Acetylcholine is released from the nerve and synapses on the muscle, and that's how a muscle knows to make a contraction. Since this muscle is going a long period of time without getting any acetylcholine, it starts, becoming like an addict for this acetylcholine. It's going to start expressing acetylcholine receptors all over its surface. And so any rogue acetylcholine that just happens to be in our bloodstream may bind to those receptors and cause a little bit of a contraction. Not the full muscle contraction, but a tiny bit of a contraction. And that's what we refer to as a fasciculation. And it's one of the long-term problems in lower motor neuron lesions. Because there's no nerve going to the muscle, we will not see reflexes. Upper motor neuron is reigning over right now, and so we will not see tone, we will not see any flexing. Babinski reflex is gone as well. No spastic paralysis. We will see flaccid paralysis. Our patient's muscle should be completely relaxed. Okay? And obviously we won't see any class 9 specific spasticity because we cannot flex our muscle. Okay? And so there's some kind of mnemonic here if you want to memorize it this way. I think my way is a little bit better. Thinking about upper motor neuron, it comes from the brain. This is the teacher in a second grade class. Lower motor neuron is the student who's just spastic, running around. You need that upper motor neuron telling the lower motor neuron what to do. Otherwise, it's just going to be flexed all the time. Okay, and that's a big problem. So this is a hot topic for the step 1. You'll see a lot of questions on this. Even in your U-World, you'll see a lot of questions on this upper versus lower motor neuron. Do you have any questions on this right now?
No.
No?
Perfect, thank you.
Okay, good, you're welcome. Have you heard it described in this way before, or how did you kind of learn it when you learned it?
No, never, but I love it because I have a spastic child at home, so I know how it is.
You got a little lower motor neuron at home, okay. That's
so
good.
That helped a lot with the, I'm very good with images, and so this is perfect.
I'm the same way. I think of so many crazy ways to remember these things, but it helps, definitely helps. Okay, so getting into the central nervous system, here is our cerebral cortex. Isn't it beautiful? This is an image from our first aid, step 1, which we love, and it shows all of the more important things that we need to know more important areas, I should say, that we need to know from the cerebral cortex. So starting big picture, our frontal lobe, our parietal lobe, occipital lobe, and temporal lobe. Occipital lobe's primary job is going to be for processing vision. We have an entire lobe just for processing vision. Temporal lobe is going to be synthesis of a lot of different sensations, but if you had to pick one, auditory would be the one that's pretty important for temporal lobe. Parietal lobe is going to be synthesizing a lot of our sensations. So you can see our somatosensory cortex is within our parietal lobe. And our frontal lobe is responsible for a lot of decision making as well as movements. Okay, when I think of making a decision, I think of taking action. And the premotor cortex is all about action. When we think, okay, I'm going to crack this egg and open it over a frying pan, we need a premotor cortex to tell us how much force to put on that egg, how to hold the egg as we crack it, right? We have all of these plans that are ready-made in our brain, and that's located in the premotor cortex. So when we decide we're going to crack an egg, those plans are going to go right here to our primary motor cortex. This motor cortex is going to is where we have all those primary upper motor neurons that we just talked about in the last slide. This is where they live, those upper motor neurons. This is in the primary motor cortex. Okay, so they get all their information from our premotor cortex. How do we make the plan that we want to crack the egg? We have the prefrontal cortex, which is not labeled on here, but our very front of the brain is the part of our brain that's responsible for our higher level thinking and making plans. Okay. There's a number of other areas that are denoted on here. We have our frontal eye field, our prefrontal association area, our limbic association area, and so these, to be honest with you, you may get a question on your Step 1 exam that just gives you a picture of a brain and asks you for the frontal eye field, for example, and has a bunch of labels A, B, C, D, E. And so I would take the time to sort of get a general idea of where these things are located. The answer choices are not going to be located right next to each other, so you don't need to memorize the creases in the brain and say, oh, this is 5 creases north, 3 creases south. Don't worry about that. Just have a general idea that the frontal eye field is in the prefrontal cortex. Premotor cortex should be near the primary motor cortex. The central sulcus is a really great landmark. When you see the central sulcus, you know right next to it in front is our primary motor. Right next to it behind is our somatosensory cortex. Okay, so central sulcus is really something that you want to identify quickly when you get one of these types of questions. Okay. The other 2 areas that are super, super important, Wernicke's area, which is within the temporal lobe, and Broca's area, which is within the frontal lobe. Okay. So Wernicke's area is important for language processing. When you hear someone say something, understanding what that meant, and then translating that into meaningful, making a plan for of what to say. Okay. Broca's area is for putting that plan into action. So Broca's area is all about, look how close this is to the motor cortex. Okay. So that tells you that this is about moving the muscles of our mouth and our larynx to produce the words that we plan to make in our Wernicke's area. All right, so Broca's area is all about moving our boca. Okay, boca. This is all about how are we going to move our boca to make the words that we wanted to say. All right, and so a lesion in each of these areas looks very differently. I know you know what I'm getting at. And so with Wernicke's aphasia and Broca's aphasia, they both look different, and now you can kind of see why. With our Broca's area, it's laying right on top of our motor cortex, so that's all going to be a motor presentation. Where in Wernicke's area, it's right next to our auditory cortex. So this is going to be hearing, understanding, and producing meaningful words. Okay, so that's sort of how the 2, from the anatomy perspective, kind of overlays the pathology. Okay, and I think I've talked about just about everything we need to talk about here. There's a Sylvian fissure, not terribly important, but that's kind of the fissure between the temporal lobe and the rest of the brain. Okay, great. So now we're going to start talking about different areas of the brain, starting with the basal ganglia. Okay, so the basal ganglia is considered one of the very, very old parts of our brain. So if we take a look at our basal ganglia, you can see, some of our gray matter embedded with white matter. Components of our basal ganglia include the caudate, which you can see here on the image. Here's our caudate. Putamen. Here's our putamen here. Globus pallidus, subthalamic nucleus, and our substantia nigra. Okay. We can combine some of these. The caudate and putamen are pretty close together, and so we can call that the striatum. Putamen and globus pallidus we call the lentiform nucleus because it kind of makes a lens shape here. Don't worry too much about that. We're going to talk about what you need to know from each of these. And then look, internal capsule. We talked about internal capsule a few slides ago when we said that our primary upper motor neurons travel through this internal capsule to get to the medulla where it's going to cross over. Okay? So what is the basal ganglia for? It's all about the action, behavior, cognition. So, this is going to help modulate our action via our excitatory and inhibitory pathways. When we talk about Parkinson's disease, this is where a lot of the pathology is. We make a decision to take an action. We say, I'm going to raise my hand 1 foot in the air. Okay? Executing that plan means, we have those nerves in the motor cortex. It's going to, the thalamus is going to be involved. We want to make sure when we raise our hand from here to here, we're not overshooting it. We're not trembling when we get there. We're not undershooting it. And so the basal ganglia is going to be important for modulating action, gatekeeper for movements, muscle tone. How much force are we putting into our movements? This is kind of our regulatory system to make sure we're not overdoing it or underdoing it. Okay? Behavior, our drive and initiative in our nucleus accumbens and the amygdala, as well as cognition, learning certain skills. And the final product of basal ganglion cortex function is a change in muscle tone. Okay, great. So movement and emotion. So voluntary movements and spontaneous movements of our face use different pathways. We just talked a minute ago about our volitional pathway in our arms and legs. There's a different pathway for the muscles of our face, which is something to know. If you have a lesion in certain parts of your brain, you'll still be able to smile. In other parts of your brain, you will not. Okay, not terribly high yield, but something that is interesting to know. So our basal ganglia loops. This is a slide that I'm going to talk about now, but I'm also going to come back to again when we meet next time, which I believe is on Monday, because it's just so important, and it's something that that they love to ask you about because it's so complicated. It's so darn complicated, this idea. So let's go through it together. We're meeting on Monday. Great. So when we meet on Monday, we'll go through this again. But just kind of following this pathway from A to Z. So here's our motor cortex. Our motor cortex says, I'm going to raise my hand from here to here. I'm going to raise it 1 foot. Now, that decision is first going to go through our basal ganglia. We need to modulate that activity before we do it. So we have this stimulatory pathway coming from our motor cortex that says, hey, putamen, what's going on? I just made a decision that I want to move my arm. Can you make sure that I move it the right amount, not too much, and in the right way? So when we synapse here in the putamen, we have a inhibitory pathway that synapses on the globus pallidus externa. And so here you can see in our direct pathway, it's going to synapse on the globus pallidus interna. From the globus pallidus interna, it's going to send a inhibitory signal to the thalamus, and that will inhibit the thalamus from sending a positive signal here. So overall, we have an overall excitatory pathway here. Our direct pathway is going to be overall excitatory. Now, we also are going to balance that with the indirect pathway, which is going to stimulate the globus pallidus interna. And so basically, you're inhibiting an inhibitor, which is stimulating, but essentially this is going to be an inhibitory pathway. Okay, so we have one inhibition at the globus pallidus externa, one inhibition at the STN, the subthalamic nuclei, and that is going to stimulate the interna. However, that would be inhibiting the thalamus, which would be stimulating the motor cortex. So just know that overall, our indirect pathway is going to be inhibitory, our direct pathway is excitatory. Okay, so great. So we have one exciting, one inhibiting. What is the point of this? They cancel each other out. So in terms of modulating our what we want to do, what our actions will be, we have a secondary pathway that utilizes dopamine that is going to increase the activity of whatever we're trying to do. Okay, so it excites the direct pathway, which leads to more excitation, and inhibits the indirect pathway, leading to excitation, right? Because inhibitory pathway is inhibitory. I'm sorry, indirect pathway is inhibitory, right? And so this has a lot of important parallels for Parkinson's disease. If activated or if direct pathway is compromised, we will see symptoms of Parkinson's disease with decreased movement. Hyperkinetic effect, if activated, would be Huntington's disease, where we see too much activity. Okay? And so that's sort of a quick overview. When we meet on Monday, we're actually going to draw this from scratch. And I think it's a lot easier to understand when we draw it from scratch what's happening with this inhibition and excitation. Okay? Great. So, with Parkinson's disease, what we see is a degeneration of dopaminergic neurons in the substantia nigra. Okay? In the substantia nigra. This is going to be an answer choice. You need to know that you lose these pigmented dopamine neurons in the substantia nigra, and that tissue is replaced with Lewy bodies containing something called synuclein, okay, which is just a protein that is not great to have around, doesn't really contribute or help you out at all. It's just kind of replacing what used to be there, which was good stuff, right? Okay, and so signs and symptoms, we look for tremors, a resting or pill rolling tremor. Important thing here, if you have a patient with Parkinson's and they have this tremor when they're just sitting not doing anything, they'll have this kind of pill rolling tremor. When you say, hey, can you take this water bottle out of my hand, the tremor will disappear. The tremor is going to disappear. That's an important differentiating factor with Parkinson's disease, is that if they are reaching out for something, if they make an intentional movement, that tremor is going to disappear. Okay, so resting or pill rolling tremor that disappears with movement. For rigidity, we're looking for this lead pipe rigidity once again, with plasticity, cogwheel rigidity, where it's just very slow movements. And this is different from our upper motor neuron, right? So upper motor neuron was that clasp knife rigidity with the arm kind of releasing very quickly. With lead pipe rigidity, they're just kind of like resisting whatever movement that you try and get them to do. They just, whatever, if you were to hold hands with this person and try and swing your arm, they would resist in every single direction. They're not trying to resist, but because of this fact, they just resist it. Okay. Akinesia, inability to initiate movement. So they have this mask-like, expressionless face. Will be described for you. A stooped posture and a slow, it's considered fenestrating gait, where it's really shuffling their feet. And typically it starts unilaterally and may progress to bilaterally. Okay. Because we have a dopamine deficiency here, we need to treat with dopamine. That makes sense. Dopamine cannot cross the blood-brain barrier, but L-DOPA can. So we are going to give L-DOPA in order to try and increase the levels of dopamine in the brain. Carbidopa will prevent that conversion of L-DOPA to dopamine in the periphery. So that is helpful because any dopamine you have in the periphery is now going to kind of be shunted up into the brain and restore that imbalance of dopamine that you're having. Treatment for Parkinson's disease is to balance the amount of dopamine and acetylcholine. We really have a deficiency of dopamine, which results in an excess of acetylcholine. And so anti-acetylcholine drugs are very helpful. Okay. So in Parkinson's disease, dementia may be a late outcome. So before I move on from this anti-acetylcholine, the drug that you're looking for in your answer choices is going to be benztropine. Benztropine is the anti-acetylcholine drug that will help these patients. It's not first line. First line obviously is going to be dopamine or L-DOPA, and then you can move on to carbidopa. Typically, actually, when you treat these patients, you're going to give them a pill with carbidopa and L-DOPA both in the same pill, right? Just because it's so helpful and effective. However, if that's not working, you can give benztropine, which is our anti-acetylcholine. How do you remember that? You can remember that I want to park my Benz, Mercedes-Benz, because we are fancy doctors, rich and fancy doctors. We all drive Benzes, right? And so when we park our Benz, that tells us that we use an anti-acetylcholine drug, and that helps restore that balance. Okay. Secondary Parkinson's disease can be seen in patients that have excessive head trauma with some of these signs and symptoms. Okay, not these are not terribly high yield. Parkinson's disease is really enough of a disease on its own. You're not going to get secondary Parkinson's disease. You will get questions on Huntington's disease, so be able to differentiate these two and know that this is a genetic chromosomal abnormality with anticipation. So what is anticipation? Anticipation is a genetic mutation that gets worse through generations. Okay? And so in the example of Huntington's disease, what we have is the CAG repeat. Okay, so in the genetic code, we have this CAG repeat. And as the repeats start to accumulate, so in the first generation, we may have, say, the CAG repeat times 30. Okay? However, we get this mutation where in the next generation, so for the kids, now the kid is going to have 39 CAG repeats. Okay, so now we're going to start to have Huntington's disease present when the patient is about 80 years old. Okay, now in the next generation, we have 57 CAG repeats. Okay, and so in this generation, in the grandchild of the original person, now this patient is going to present when they're in their 60s. Okay, and now in the next, they still were able to have kids, right? So now in the next generation, we have 125 CAG repeats. Okay, and now this patient is presenting when they're in their 40s, and they were still able to have kids, and now we have 200 CAG repeats, and now this this patient is basically doomed from the day that they're born. Okay, and don't have a very very good prognosis. Okay, they may die when they're in their teens when you have that many CAG repeats. These accumulate, and they are going to be apoptotic to our neurons. Right? These proteins are actually going to go to our neurons and destroy those neurons. And with this genetic anticipation, what we're looking for is a patient that's presenting with some of the symptoms of Huntington's, and they're going to say, yeah, my dad had some kind of problem, but he was much older. I don't understand why I would have this problem at such a young age. Well, we may have Huntington's disease where there's some anticipation, meaning they are going to present much earlier. Not much of a treatment we can give. It's really going to be a symptomatic type treatment, reduce some of these psychiatric symptoms of depression and mania, and the risk of suicide is very high in these patients, okay, unfortunately. What are the signs and symptoms of Huntington's disease? We're looking for this word, chorea. This is almost like a dance-like movement that you see as these patients lose the ability to control their musculature. There are other types of chorea you can see, such as in strep infections. You see something called Sydenham's chorea, chorea gravidarum in pregnancy. However, Huntington's disease is sort of the OG chorea, and it's essentially just sort of a spastic and random movement of the muscles. Okay. To get a better idea of what chorea looks like, I recommend watching a YouTube video where it shows chorea, because it's something that you want to be able to identify if you are given a little video or something like that in your questions. Okay. Cognitive, we are looking for some dementia, difficulty in learning skills, which progresses to cortical dementia, depression, and suicide as well. Okay. So that is our Huntington's disease. Some other lesions we can have in our basal ganglia. So Wilson's disease is a genetic error in copper metabolism where we absorb way too much copper. And so what we see is a hepatolenticular degeneration, which is sort of liver damage due to all this extra copper. Kayer-Fleischer ring is on our eyeball. Here's our iris. There's a pupil. Here's the iris. Kayer-Fleischer ring is a ring of copper right along the limbus, or the outer part of the iris. Okay. Dystonia, which is inability to use the muscles, wing beating, flapping, tremor. Our treatment here, penicillamine. Know this drug as a copper chelating agent. Penicillamine is going to come back again and again, but in Wilson's disease, it actually is going to gobble up all that extra copper, so it doesn't cause these accumulation in the basal ganglia. Okay. With Wilson's disease, I would say that's the one thing you need to know, is accumulation of copper in the basal ganglia. That's the most important part. Hemibolismus, when we have a lesion of the contralateral subthalamic nucleus, we're going to have a rapid, swinging, involuntary movement of limbs. It should be upper and lower limbs. The way they'll describe your patient is a patient that is just randomly swinging their arm and leg on one side, the other side is completely fine. And so what they're going to ask is what side is the lesion? You need to know it's contralateral. For hemibolismus, it's going to be contralateral. Okay? All right, great. So we are going to stop here with this review.